Good afternoon, guys. I think we will start. All right. So,
Yes, sir.
today's topic is thyroid and its functions. And it's quite an interesting topic and it's become very routine. Once upon a time, thyroid was very special. Now, I think every woman who's pregnant, one of her panels has thyroid. A newborn baby has TSH. And if you put on too much weight, you lose too much weight, you have problems with pressure and diabetes, thyroid comes on. So it's nice to know how important thyroid is and what role it plays in our system, especially in relation to PTH and calcium and so on, vitamin D. So let's start with it. So we will review the anatomy and physiology of the thyroid gland, the basic functions T3, T4, FT3, FT4 will be illustrated, and method of action, role of calcitonin and parathyroid hormone become important in the presentation. Hashimoto's disease hypothyroidism and Graves' disease hyperthyroidism is explained here. The role of TSH and its relationship to T3 and T4 is explained. Interpretation of other thyroid tests such as TPO significance is explained in this presentation also. So let's start off with the question, what is thyroid gland? So thyroid is a small butterfly shaped gland located in the front of the neck below the larynx or the Walsh box. The thyroid gland makes two thyroid hormones, T3 and T4, triiodothyronine and thyroxine, which circulate in the blood system and act on virtually every tissue and cell in the body. Thyroid hormones affect metabolism, brain development, breathing, heart and nervous system functions, body temperature, muscle strength, weakness, dryness, menstrual cycles, weight loss, weight gain, cholesterol levels, and so on. So it's a multi-purpose hormone that we have in the body. So here we go. So you can see where it's placed. So you have the thyroid and the parathyroid gland. See the placement. Interesting. Okay. The history goes back to the 12th century. In modern times, the thyroid was first identified by the anatomist Thomas Wharton, whose name is also ependymized in Wharton's duct of the submandibular gland in 1656. You see, that goes back that long. Thyroxine was identified only in the 19th century. In 1909, Theodore Kocher from Switzerland won the Nobel Prize in Medicine for his work on the physiology, pathology, and surgery of the thyroid gland. The basic functions, the thyroid gland controls how quickly the body uses energy, makes proteins, and controls how sensitive the body is to hormones, the other hormones. It participates in these processes by producing thyroid hormones, the principal ones being triiodothyronine, T3, and thyroxine, which can sometimes be referred to as tetraiodothyronine, T4. These hormones regulate the rate of metabolism and affect the growth and rate of function of many other systems in the body. T3 and T4 are synthesized from both iodine and tyrosine. The thyroid also produces calcitonin, which plays an important role in calcium hemostasis. Hormonal output of the thyroid is regulated by the thyroid stimulating hormone, TSH, produced by the anti-pituitary, which itself is regulated by thyrotropin releasing hormone, TRH, produced in the hypothalamus. Somebody is coming in. Okay. Welcome now, Amna. We've just started. so you can catch up. You haven't lost much of the slides. All
Sure,
right. So
ma'am. Hello, everyone.
yeah. So we are talking in terms of basic thyroid functions: T3, T4, TSH, TRH, and also telling you how important the role is of the pituitary and the hypothalamus. Now this is the chemical structure. T4, thyroxine. On top you got 353 triiodo T3. This is under positions, and on the right hand side you've got the thyroid gland, and you've got the pituitary, which is controlling TSH, stimulating hormone, which in turn in a way controls T4, progesterone and selenium, and then in turn it controls T3, which is the active hormone. T4 is the inactive hormone, keep it in mind. T3 activates and energizes all cells of the body. Keep that in mind. Alright? The physiology. The primary function of thyroid is the production of the hormone T3, T4, and calcitonin. Up to 80% of T4 is converted to T3 by peripheral organs such as the liver, kidney, and spleen. T3 is several times more powerful than T4, which is largely pro-hormone, perhaps 4 or even 10 times more active than T3. Okay, so you have a little picture below and you can see how it works. Okay, I think we will share the picture again in the next slide if I'm not mistaken. Here we go. You can see the thyroid system. You have the anterior pituitary gland, which is in the brain. It releases thyroid releasing hormone TRH. There's a negative feedback involved, and in turn acts on TSH, the thyroid gland, which is in front of your voice box. And then you have the conversion, you have the bifurcation of T3 and T4. So increased metabolism, growth and development, increased catecholamine effect. Now this catecholamines, we talk in terms of blood pressures. And in the figure, you've got the same thing. You've got the hypothalamic pituitary thyroid axis. See how one controls the other. You've got the hypothalamus, you've got the pituitary, which in turn acts on the TSH on the thyroid gland, and there are two ways. You've got T4 converted to T4, T3 in the muscle, and in turn T3. It targets tissues like heart, liver, bone, and the central nervous system. Okay. Synthesis of the thyroid hormones as seen on an individual thyroid follicular cell. Thyroglobulin is synthesized in rough endoplasmic reticulum and follows the secretory pathway to enter the colloid in the lumen of the thyroid follicle by exocytosis. Meanwhile, a sodium iodide supporter pumps iodide actively into the cell, which previously has crossed the endothelium by largely unknown mechanisms. So I think you know how important iodine becomes in this metabolism. And you can see how iodine is pumped in, the tyrosine playing a part, which in turn, somebody's coming, in turn acts on T3 and then T4. Well, just a second, guys, somebody's coming in. Parul. Good morning, Parul. Can you hear me? Thank you. All right. So we're coming back to the synthesis. I'll repeat it. Synthesis of the thyroid hormones as seen on an individual thyroid follicular cell. Thyroglobulin is synthesized in the rough endoplasmic reticulum and follows the secretory pathway to enter the colloid in the lumen of the thyroid follicle by exocytosis. Meanwhile, a sodium iodide supporter pumps iodide, whatever I minus, so minus up there, actively into cells which previously has crossed the endothelium by largely unknown mechanisms. We don't know how it does it, but it does. Synthesis further. This iodide enters the follicular lumen from the cytoplasm by transporter pendrin in a purportedly passive manner. In colloid iodide is oxidized to iodine by an enzyme called thyroid peroxidase. Iodine is very active and iodinates the thyroid globulin at tyrosine residues in its protein chain, in total containing approximately 120 tyrosyl residues. In conjunction, adjacent tyrosyl residues are paired together. The entire complex re-enters the follicular cell by endocytosis. Proteolysis by various proteases liberates thyroxine and triiodal thyroxine molecules, which enters the blood by largely unknown mechanisms. So this is the way it works. You can take a look at it. I'll stop for some time and just see how it works. It's fascinating. So we said the iodide enters follicular lumen from the cytoplasm of the transporter pendrin in a purportedly passive manner. The colloidal iodide is oxidized to iodine by an enzyme called thyroid peroxidase. Iodine is very active and iodinates the thyroglobulin at tyrosyl residues in its protein chain, and it's in containing approximately 120 tyrosyl residues. In conjunction, adjacent tyrosyl residues are paired together. The entire complex re-enters the follicular cells by endocytosis. Proteolysis by various proteases liberates thyroxine and triiodal molecules, which enters the blood by largely unknown mechanisms. So take a look at it, and meanwhile, let's get somebody else. Somebody's knocking. Nazneen, okay. Hi Nazneen, welcome. You made it today. Good job. All right, let's go further. All right, so this is what I just spoke to you about. How iodine 0 is converted to iodine and the role iodine plays in T3 and T4. Take a look.
Good afternoon, ma'am.
Good afternoon. Good afternoon. I'm glad you made it.
Good afternoon, ma'am.
Good afternoon. So I said good morning to you, Parul.
Yeah,
You had to
good
wake up
morning.
early. Thank you. Okay. So Shiri said that her boss called her last moment, so she's going. She'll try to connect if she can. Rohana's not here right now. Maybe she's busy somewhere. All right. Let's go further.
मेरा ट्रेनिंग चल रहा है हाँ
हाँ जी.
क्या आपकी ट्रेनिंग चल रही है हाँ मुझे भी खाना है
Nazneen, mute.
अभी ये क्या बोल रहे हैं केडी वो
Nazneen, mute.
इसको लिखने को और
All right.
को लिखने को
Nazneen, mute. Okay, so tyrosine, the T4, is synthesized by the follicular cells from free tyrosine, and the tyrosine residues of the protein called thyroglobulin, Tg. So get these symbols with you. Iodine is captured by the iodine trap by the hydrogen peroxide generated by the enzyme thyroid peroxidase, TPO, and linked the 3 and 5 sites of the benzene ring by tyrosine residues on Tg and on free tyrosine. Upon stimulation of the thyroid stimulating hormone TSH, the follicular cells reabsorb Tg, and Tg is thyroglobulin, you know that, and cleave the iodinated tyrosine from Tg in lysosomes, forming T4 and T3. In T3, one iodine atom is absent compared to T4, as T3 and T4, and releasing them into the blood. Deiodinase enzymes convert T4 to T3. Thyroid hormone secreted from the gland is about 80 to 90% T4 and about 10 to 20% T3. Understand this, it's quite simple, especially the role of TSH. Okay? Okay? So T3 and T4 regulation. The production of thyroxine and triiodothyronine is regulated by thyroid stimulating hormone. So this TSH becomes very, very important. And you'll have to know the relationship in hypothyroidism and hyperthyroidism is inverse. Released by the anterior pituitary. The thyroid and thyrotropes form a negative feedback loop. TSH production is suppressed when the T4 levels are high. Guys, keep that in mind. The TSH production itself is modulated by thyrotropin releasing hormone TRH, which is produced by the hypothalamus and secreted at an increased rate in situations such as cold exposure to stimulate thermogenesis. TSH production is blunted by somatostatin, SRIH levels, rising in glucocorticoid and sex hormones, estrogen and testosterone, and excessively high blood iodine concentrations. So we'll see how TSH controls your T3 and T4. An additional hormone produced by the thyroid contributes to the regulation of blood calcium levels. I told you it regulates your calcium. Parafollicular cells produce calcitonin in response to hypercalcemia, that's high calcium. Calcitonin simulates the movement of calcium into bone in opposition to the effect of the parathyroid hormone. And I think we saw that last time. However, calcitonin seems far less essential than PTH, as calcium metabolism remains clinically normal after removal of the thyroid gland, thyroidectomy as it's called, but not the parathyroids. Significantly elevated levels of calcitonin are a good indicator of C-cell hyperplasia or medullary thyroid cancer, guys. You keep that in mind. I'm repeating the last sentence again. However, calcitonin seems far less essential than PTH, as calcium metabolism remains clinically normal after the removal of thyroidectomy, but not the parathyroids. Significantly elevated levels of calcitonin are a good indicator of C-cell hyperplasia or medullary thyroid cancer. So it is a cancer marker for thyroid, okay? And you can do it in the lab. Again, we're taking a look at T4 and T3. So I told you T4 is inactive, converted to T3, which is more active. So we come to disorders of the thyroid. Thyroid disorders include hyperthyroidism, abnormally increased activity, hypothyroidism, abnormally decreased activity, and thyroid nodules, which are generally benign, thyroid neoplasms, but may be thyroid cancers. All these disorders may give rise to goiter, that is an enlarged thyroid. So get hyperthyroidism very clearly in your mind, hypothyroidism, thyroid globules, and goiter. And I'm sure you've seen people with this. So we come to hyperthyroidism. Or overactive thyroid is the overproduction of thyroid hormones T3 and T4 and is mostly caused by the development of Graves' disease, an autoimmune disease in which antibodies are produced to stimulate the thyroid to secrete excessive quantities of thyroid hormones. Is this much clear what Graves' disease does? The disease can result in the formation of toxic goiter as a result of thyroid growth in response to lack of negative feedback mechanisms. It presents with symptoms such as thyroid goiter, producing ice, exophthalmos, palpitations, excess sweating, diarrhea, weight loss, muscle weakness, an unusual sensitivity to heat. The appetite is often increased. So this is hyperthyroidism. You have an overactive thyroid. And take a look at the picture below. The eyes in particular. Alright? So the pathogenesis of Graves' disease, can you see the goiter? Can you see the goiter on the left hand side? So you have sonography done on the thyroid, and the pathogenesis of Graves' disease, activated beta cells which stimulates antibodies to TSH receptors, and you've got follicular cells in the thyroid which are in excess. In Graves' disease, you got increased sympathoadrenogenic activity and metabolic rate. Exophthalmos, warm pulsating goiter, tachycardia, fine tremor, and
Maxillary.
Pretibale maxillema. It suppresses TSH, gives you high T3, T4. So this is inversely related. So if you have a low TSH, chances are your T3, T4 are high. And it's inverse in the other way around. Advantage of free T3 and free T4 over regular T4. So nowadays, most of us, we prefer doing FT3 and FT4. Triiodothyronine is a thyroid hormone that circulates in blood almost completely bound to carrier proteins, 99.5%. The main transport protein is thyroxine binding globulin, TBG. However, only the free unbound portion of triiodine T3 is believed to be responsible for the biological action. Furthermore, the concentrations of carrier proteins are altered in many clinical conditions such as pregnancy. That's the reason why thyroid tests are compulsory in all pregnant women. Understand this. So T3 is a thyroid hormone that circulates in blood almost completely bound to carrier proteins. The main transport protein is thyroxine binding globulin, TBG. However, only the free unbound portion of the triiodothyronine, free T3, is believed to be responsible for the biological action. Furthermore, the concentrations of carrier proteins are altered in many clinical conditions such as pregnancy. And that's the reason why it is now compulsory for most pregnant women. Further, in normal thyroid function, as the concentration of carrier protein changes, the total triiodine level also changes so that the free triiodothyronine concentration remains constant. In a normally functioning thyroid, this is not necessarily so. Measurement of free triiodothyronine concentration therefore correlate more reliably with your clinical status than the total triiodine levels. So FT3 scores over plain T3. For example, the increase in total triiodothyronine levels associated with pregnancy, oral contraceptives, and estrogen therapy result in higher total T3. So T4 and TSH relationship with the pituitary. The amount of T4 produced by the thyroid gland is controlled by another hormone which is made in the pituitary gland located at the base of the brain called the thyroid stimulating hormone, TSH. The amount of TSH that the pituitary sends into the bloodstream depends on the amount of T4 that the pituitary sees. If the pituitary sees very little T4, then it produces more TSH to tell the thyroid gland to produce more T4. So I told you it's inversely related. Once T4 in the bloodstream goes above a certain level, the pituitary's production of TSH is shut off. Please take a look at the slide and understand it. The amount of T4 produced by the thyroid gland is controlled by another hormone which is made in the pituitary gland located at the base of the brain called the TSH. The amount of TSH that the pituitary gland sends into the bloodstream depends on the amount of T4 that the pituitary sees. If the pituitary sees very little T4, then produces more TSH to tell the thyroid gland to produce more T4. Once the T4 in the bloodstream goes above a certain level, the pituitary gland of the TSH is shut off. So you can see how the pituitary controls T4 and in turn T3. Here we go. You've got the hypothalamus that makes the TRH, which in turn acts on the pituitary, sends out TSH, and that in turn controls the T3 and the T4. So you have a depends on what your body needs. You can have a normal or excess or low T3s and T4s. A little on TSH. Thyroid stimulating hormone, also known as TSH or thyrotropin, is a hormone that stimulates the thyroid gland to produce thyroxine T4, then triiodothyronine, that's T3, which stimulates the metabolism of almost every tissue in the body. It's a glycoprotein hormone synthesized and excreted by the thyrotrope cells in the anterior pituitary gland, which regulates the endocrine function of the thyroid gland. Hypothalamus in the base of the brain produces thyrotropin releasing hormone TRH. TRH stimulates the pituitary gland to produce TSH. Somatostatin is also produced by the hypothalamus and has an opposite effect on the pituitary production of TSH, decreasing or inhibiting its release. So keep these words in mind. All right. The TSH receptor is found mainly on thyroid follicular cells. Stimulation of the receptor increases T3 and T4 production and secretion. Stimulating antibodies to this receptor mimics TSH and causes Graves' disease. In addition, HCG shows some cross-reactivity to the TSH receptor and therefore can stimulate production of thyroid hormones. In pregnancy, prolonged high concentrations of HCG can produce a transient condition termed gestational hyperthyroidism. Keep this in mind. Let's take a look at it. So in addition to HCG shows some cross-reactivity to the TSH receptor and therefore can stimulate production of thyroid hormones. In pregnancy, prolonged high concentrations of HCG can produce a transient condition termed as gestational hyperthyroidism. That is the reason why doctors monitor T3, T4 and TSH during pregnancy. So it says run TSH normal, so that represents normal TSH. If TSH is low, run FT4. Normal or low FT4 with TSH. Then you said run T3. Report TSH, FT4 and FT3. On the other side, if you have a high TSH, run FT4. Report TSH and FT4. So this is hypothyroid. And here on the other side, you've got hyperthyroid. So the importance of TSH assays. TSH concentrations are measured as part of thyroid function tests in patients suspected of having an excess or deficiency of the thyroid hormones. So either it's hyperthyroid or hypothyroid. Interpretation of results depends on both TSH and T4 concentrations. In some situations, measurements of T3 may also be useful. A TSH assay is now also the recommended screening tool for thyroid disease. Recent advances in increasing the sensitivity of TSH assay makes it a better screening tool than FT4. The general therapeutic range, target range of TSH level for patients on treatment ranges from zero point 0.3 to 3 UIU per ml. So there are all sorts of experiments being done. So the other thyroid tests of importance are resin thyroid uptake, UT uptake. In the resin T3 uptake test, labeled hormone is added to the patient's serum. If there's an increase in the binding capacity, more labeled hormone will be found to the binding proteins, and thus less will be left free in the serum. The free labeled hormone in the serum is measured and usually reported as a percentage of the total labeled hormone that is added. If a patient has high total T4, it may be an overproduction of the thyroid hormone, hyperthyroidism, or to an excess of one of the thyroid binding proteins, usually thyroid binding globulin, TBG. If the high total T4 is secondary to high TBG, the resin T3 will be low, otherwise it will be normal or elevated. Now this is a little complicated to understand, so you should take your time to read it. Usually we have better, and in my books there are better tests than this. This is the resin uptake. Another way of putting this is that if total T4 and T3 deviates from the normal in one direction, the resin T3 uptake deviates in the opposite direction. Then the abnormality is due to change in binding capacity, otherwise it is secondary to a true change in thyroid function, hyper or hypo. So this is a plain introduction to it. Another way of putting this is that if total T4 and T3 deviates from normal in one direction, the resin test deviates in the opposite direction, so they're inversely related. Then abnormality is due to changes in binding capacity, otherwise it is secondary to a true change in thyroid function. For example, if the binding capacity is increased because of high estrogens, the free labeled hormone will be decreased and the resin T3 uptake will be decreased. So we come to thyroid antibodies, which is important. Autoantibodies of clinical interest in thyroid diseases include thyroid stimulating antibodies, TSAB, TSH receptor binding inhibitory immunoglobulins, I think it's II, anti-thyroglobulin antibodies, anti-TBAG, and thyroid peroxidase antibody, anti-TPO antibodies. Of these, anti-TPO antibodies has emerged as the most generally useful marker for the diagnosis of management of autoimmune thyroid disease. Anti-TPO antibody was historically referred to as an antimicrosal antibody. So keep this in mind. Anti-TPO antibody has emerged as the most generally useful marker for the diagnosis and management of autoimmune thyroid disease. The anti-TPO antibody was historically referred to as the antimicrosomal antibody. The anti-TPO antibody was historically referred to as an antimicrosomal antibody. Let's see. The thyroid peroxidase enzyme responsible for iodinating tyrosine residues in the thyroglobulin molecule was subsequently identified as a major microsomal content recognized by the autoantibodies. New improved assays designed in the wake of this insight have been rapidly replacing the older antimicrobial antibody assays. The anti-TPO antibodies mediate antibody-dependent thyroid cell destructions, level correlate with the active phase of the disease. Measurement of this autoantibody is useful for resolving the diagnostic dilemma presented by the apparent inconsistency between elevated TSH and normal free T4 results. So this test does become important. So we come to thyroid stimulating immunoglobulin. TSI is an autoantibody present in Graves' disease, the most common cause of hyperthyroidism. TSI mimics TSH to stimulate the thyroid cells, causing the thyroid gland to secrete excess hormones. The TSI test detects TSI circulating in the blood and is usually measured in specific instances in people with Graves' disease. When the disease is obscure during pregnancy and to determine if remission has occurred. So I'm repeating this. The TSI is an autoantibody present in Graves' disease, the most common cause for hyperthyroidism. TSI mimics TSH by stimulating the thyroid hormones, causing the thyroid gland to secrete excess hormones. The TSI test detects TSI circulating in the blood and is usually measured in specific instances in people with Graves' disease. I think you saw the picture. And the diagnosis is obscure during pregnancy and to determine if remission has occurred. Further high TSH, normal T4. Abnormally elevated TSH and euthyroid T4 results. A positive anti-TPO test provides strong evidence for early subclinical autoimmune disease. So here you've got an elevated TSH and a normal T4. This assay is also used to monitor response to immunotherapy, to identify at-risk individuals with family history of thyroid disease, and as a predictor of postpartum thyroiditis. Approximately 10% of asymptomatic individuals have elevated levels of anti-TPO antibody and may suggest predisposition to thyroid autoimmune disease. Elevated levels are found in virtually all cases of Hashimoto's thyroiditis and approximately 85% of Graves' disease. And we'll take a look at both. We have already. So thyroid binding globulin TBG remains an esoteric thyroid function test that is useful for the differential diagnosis of patients presenting with clinically abnormal levels of total thyroid hormone levels, but no other clinical signs or symptoms of thyroid disease. Depending on the genetic determinants, the patient's health status, including pregnancy and medication, TBG levels can vary widely from the very elevated to very low. Low hormone levels also adjust according to maintain free thyroid hormone levels within the euthyroid range. In certain situations, the knowledge that grossly abnormal thyroid hormone levels are not the consequences of a thyroid disorder may be very assuring. And although not widely used, there have been some interest in the ratio of total T4 to TBG, thyroid hormone binding ratio, as an index of free T4 levels. So there are various permutations and combinations that these doctors get into. So thyroglobulin is only produced by thyroid tissue, and this makes it an extremely specific marker for functioning of thyroid tissue. The complete absence of TG provides strong evidence for the absence of any functional tissue. Thus, tests for remaining thyroid tissue are particularly important for monitoring thyroid cancer patients, for residual, metastasized, and recurring thyroid issues after thyroid has been completely removed. Okay, so thyroglobulin is monitored. So you also have the radioactive iodine uptake. AIU primarily measures the activity of thyroid active iodine pump, which is regulated by TSH. It is not used for initial documentation of hyperthyroidism, but as a secondary test to differentiate between true and other forms of hyperthyroidism. This thyroid RAIU test is elevated in true hyperthyroidism, including TSH secreting primary adenomas and PPTH Graves' disease, trophoblastic disease, toxic adenoma, and multinodular goiter. In hypothyroidism, RAIU may be elevated, low, or normal, and changes over time may be due to transient nature of some forms of the disease. So this is a radioactive uptake test. Before that, what did it say? Something's there. Okay. So these are your tests that you can do for thyroid function, the abbreviations, and the normal ranges. So you've got thyroid stimulating hormone, you've got free thyroxine, you've got serum triiodine, radioactive iodine 123 uptake, radioiodine scan gamma camera, free thyroxine functions, serum thyroxine, thyroid hormone binding ratio, free thyroxine index, free thyronine I, the thyroidine, free T3 index, thyroxine binding globulin, TRH stimulating test, serum thyroglobulin I, thyroid macrosomal antibody titer, and thyroglobulin antibody titer. There are so many of them with short forms, and the normal ranges are on the right hand side. Okay. So calculations and conversions, you've got a UML converted to MUL, that's microliter per ng, nanograms per deciliter, and so on. So conversion levels are given to you here. Take a look at it for some time. So you've got in hypothyroidism, you've got low T4, high TSH. Keep this in mind. In hyperthyroidism, you've got high T4 and low TSH. This is as a test. If you know this much, you can interpret a result. All right? Okay. So typical thyroid function test results. Hyperthyroidism. Cause Graves' disease. The TSH is down, the T3, T4 is up, and your radioactive uptake is down in the early stage. And then you've got the hot and toxic stage, and you have the involvement of the thyroid nodules, and so on. Then you've got typical thyroid function test results. Hypothyroidism. Cause Hashimoto's disease. The TSH is up, T3, T4 is down or normal, and your anti-thyroid antibody is positive. Then you've got your Hashimoto's thyroidosis. Again, your TSH is up, later stage, later disease, and your anti-thyroid antibody is up. Pituitary abnormality, TSH down, and T3, T4 down. So we come to hypothyroidism. Is the underproduction of the thyroid hormones T3 and T4. Hypothyroid disorders may occur as a result of congenital thyroid abnormalities. So it says C, congenital hypothyroidism, autoimmune diseases such as Hashimoto's thyroiditis, iodine deficiency, more likely in poor countries, or the removal of thyroid following surgery to treat severe hyperthyroidism or thyroid cancer. Typical symptoms are abnormal weight gain, tiredness, baldness, cold intolerance, and bradycardia. Hypothyroidism is treated with hormone replacement therapy such as levothyroxine, which is typically required as the rest of the patient's life, right? So we are asking questions. Well, Mr. and Mrs. Pratt, it appears you have your thyroid all along. So one is very thin and one is very fat. Then you got the doctor examining for the thyroid. Okay? Again, you have little cartoon that says, why do you call it a thyroid problem? Where it's giving me an excuse for the 20 pounds I gained this year. Okay? So negative feedback mechanisms result in the growth of thyroid gland when thyroid hormones are being produced in sufficiently low quantities as a means of increasing the thyroid output. However, where the hypothyroidism is caused by iodine insufficiency, the thyroid is unable to produce T3 and T4. As a result, the thyroid may continue to grow to form a non-toxic goiter. It is termed non-toxic as it does not produce toxic quantities of thyroid hormones despite its size. You can see it over here. So tests usually which are ordered T3, T4, TSH, FT3, FT4, that's your free anti-TSH, thyroglobulin, T uptake, anti-TG and anti-TPO. These are the regular tests now. Okay? It's just a little revision, especially for you to know that what all is involved. We are not going too much into the details. It's giving you a little view of the thyroid. Some of you may have it, some of you may not have it. Or at least, basically, you have to know if somebody shows you a report, you must know how to interpret it, depending on T3, T4, and TSH. Any questions? Any questions? Something new to learn? Nazreen is giving lectures to somebody.
I think she's only enough lectures.
Any questions? Avana? Anything new in New Zealand?
Ma'am, we don't do too much of T3, T4 out here. Like, I'm not into it. But yeah, I mean, it was interesting. Another week camp.
Yeah, because this has become very routine now. कुछ नया नहीं है.
Yeah. Like, they gave it as a part of a basic blood panel. But like, in point of care, we don't have anything for thyroid.
No, I know that. I know
Yeah.
that. I know that. Munira, we have it every day. On our pregnant women, it's ordered every day, and it's ordered on our kids,
Yeah,
newborn
newborn.
babies. All of them have a TSH screen, and we do find some abnormalities, don't we? Meena, you understood?
Yes, ma'am. I'm trying to grasp, but I'll have to read it again.
You'll have to read it. Parizad,
Yes.
Parizad, Parul.
Yeah, even I.
Yes, ma'am.
It was very interesting.
Thank you, ma'am.
No, I've
I
kept
will
it.
have to
I
read it
haven't gone
again.
too much in details. I've kept it very basic. So if somebody says, "Hey, interpret this result for me," so you take a look at T3, T4, TSH, and you know how to interpret it. You know that if T4 is up, chances are T3, T4 are down, and if T3, TSH is down, then and up, you have to take a look at what is what. Is it hyperthyroid or is it hyperthyroid?
It was good information, ma'am. Like, not remembering anything much, but this is very good. The basic.
But Parul, Meena, when you all were on, I didn't think we went into those many details. Amna, did
No,
I?
we didn't
When you all
do
were on?
this. No.
No.
We didn't do this.
Rarely.
Yeah, this is good. This is
Amna,
very
your
good
batch, did we
information.
go into details? I think we did a little bit. Did we?
No, just the basic test, what routine we do, was what we did. Not. So this was really interesting. Yes, ma'am, it was like a lot of knowledge, like very good.
Parizad, what did SNDT teach you?
Yes, ma'am. Many years have passed. But still, it was refreshing. I was remembering things. Ma'am.
Okay, good. Good. Munira?
I learned many new things, ma'am, like so many things, like even me too, even I did. Yes, ma'am.
No,
So nice,
gave,
ma'am. Thank
we gave you a bird's eye view of what it is, We haven't gone too much into the metabolism, the biochemistry. It's not worth it. Is Munira on?
Yeah, she's on. I think she's not. We're keeping it on. Maybe she's on.
Hello?
Yeah. Are you on? Yeah. We're talking so much. I think we do this every day. We have these tests which are requested every day, isn't it? Nazreen, turn around.
Go busy.
have we muted her?
Yeah, she is muted herself because something is going.
Yeah, she's dictating
Yeah.
things to people.
Something is
Okay,
going on
alright,
upside down.
alright. I think then we'll end here.